Good afternoon, everyone, and welcome to the meeting of Health Overview and Scrutiny Committee on Wednesday, the 4th of March. Agenda item 1 is to ask for any apologies and to welcome you all. Welcome. Apologies, please, Sam.
Got apologies from Councillors Mark Ward, Christine Wilde and David Taylor.
Yes. So just for clarification, Councillor Taylor has replaced Councillor Matt Jenkins on this committee, and I'd like to pass my thanks on to Councillor Matt Jenkins for his contributions over the last 10 months. Thank you very much. It's been most appreciated. Thank you. If the fire alarm goes off during the course of the meeting, it's not a test. Please, the nearest emergency exit is over there, and I'm not going to tell you that the oxygen masks are going to come out the ceiling because they're not, but that's the state of play. It's not a test. We all get out there as soon as possible and safely, please. Okay, agenda item 2, any declarations of interest, please? Councillor Fry.
Thank you, Chair. I'd like to comment on the lack of interest by 3 vacancies on this committee from Worcestershire County Council members. I think it ought to be addressed because it was 2 the last time I addressed it. It is now 3. It's simply not good enough. I think we have a full quota from the districts. So County Council, I did speak to Jo Monk when I met her in town, and she said she couldn't force people, but she'd have a word. That hasn't worked, certainly. So as we are the scrutineer of health within Worcestershire, more interest should be taken. And I'd like that recorded in the minutes, please, that the lack of interest by county councillors, 3 vacancies should not be happening. We have 57 members.
Thank you very much. It's a politically balanced committee, this is. So unfortunately, the 3 vacancies are from one political group. The leader is aware of that, and as she's alluded to, she's trying to fill the vacancies. That's all I can say. But I do agree with you, it is important. And what I would say to you, Councillor Fry, is when there's any survey taking place and it involves how do you feel, what you're looking for, health and well-being is at the top right-hand corner in terms of what Joe Public would like to see, obviously up and foremost in the minds of the councillors, shall we phrase it like that. So, and it's noted. Thank you very much. Any other declarations of interest, please? And any party whip? Simon, please.
Can I just say it's Health Watch? Am I hearing that there is a political party at the council that is not represented on this committee?
No, you're not hearing they're not represented. We have 1 representation from Reform, but we have 3 vacancies from that political group. Okay.
Well, that does surprise me. Thank you.
I can assure you that I'll make up for any shortfall there may be.
I should be looking for you to quadruple the number of
and in fairness, Councillor
contributions.
Turner, you have to speak as you find. Councillor Turner has not missed 1 meeting, to the best of my knowledge, so I appreciate that. And I'd also like to thank Councillor Nick Price, who was on this committee until he was promoted to the Cabinet, so he can't join as a member, but he is actually here this afternoon. Right, moving swiftly on, because we've got some meaty subjects to discuss here. Public participation, we haven't any, so we'll move straight on to agenda item 4, which is access to GP appointments, please. Mary, welcome. Would you like to all introduce yourselves? Because I'm going to hand over to Charmaine in the first instance, actually, but it'd be good so people get to know you, because I don't think you've met all the new crew.
No, that'd be helpful, thank you. Good afternoon, everyone. My name is Mary Gay. I'm the Deputy Chief Exec for Hereford and Worcestershire ICB, part of the new cluster arrangements with Coventry and Warwickshire. I'm Director of Integration and Delivery. Nice to meet you all.
Good afternoon, everybody. I'm Charmaine Hawker, and I'm the Director of Primary Care for Herefordshire and Worcestershire Integrated Care Board and Coventry and Warwickshire Integrated Care Board.
Good afternoon. I'm Roy Williams, GP based in the Wild Forest. I'm the based at Stourport Medical Centre. I'm also the Clinical Director for our Primary Care Network, which is the Wild Forest Health Partnership, and I have a role on the Integrated Care Board as the partner member for primary care for Hereford and Worcester.
Thank you very much indeed, and welcome. Just for a point of clarification, Murray, are you covering Coventry and Warwickshire as well in your post? Yeah, thank you. Well, congratulations, because those are an extension to your existing appointments, aren't they? Charmaine, straight over to you, please.
Thank you, Chair. So, good afternoon, everybody, and firstly, thank you very much for inviting myself and my colleagues along today to talk to you about access to general practice services and particularly the impact that general practice access has on the wider urgent care services. So, obviously, we've sent a report through today and it aims to outline the various access routes to general practice. Access to general practice is one of 4 national priorities this year, so it is a significant priority both nationally and for us locally. And improving patient experience goes hand in hand with that because that is critically important into the services that our patients receive from our general practices. The report today, as I say, aims to describe the various routes and access methods for our patients and indeed, really importantly, the feedback and the experiences that our patients are actually receiving as determined by the National Patient Survey. And I think it's fair to say that Herefordshire and Worcestershire has amongst the best access to general practice services as determined by the National Patient Survey. So Herefordshire and Worcestershire became first in the country last year in 2025 for ease of access to general practice. And equally, on a monthly basis, the Office of National Statistics undertake a survey which looks at how patients are experiencing. Herefordshire and Worcestershire have been within the top 5 nationally, 10 out of the last 12 months. However, what I will say is we do appreciate that there is variation across Herefordshire and Worcestershire. And that is really important to us also so that we understand where the variation is in access and importantly how we can then support our patients to gain better access. What I will say is Herefordshire and Worcestershire ICB is fully committed to ensuring that our patients experience the best access they can to general practice services. So I think the report, as I've said, outlines various points. I think what I'll do is open it up, if that's okay, Chair, for questions on the report.
Absolutely, thank you very much indeed. So, Councillor Fordington, you've got your hand up if you'd like to kick off, please.
Good afternoon all. I've got questions straight away to ask about the increase of housing we've got. Is the system able to cope? I can see over here on our report says 59 GP practices, and that means that they're grouped in 10 primary care. Are you able to cope with all this?
Thank you. So housing growth is an issue. However, it is something that we are planning for. So across Herefordshire and Worcestershire, we've got 78 practices, 59 in Worcestershire across 10 PCNs. We are working really, really closely with council colleagues in terms of planning for housing growth. And particularly this year, there has been a 5-year forward plan in terms of capital investment that we have available to us to plan for that very issue. In addition to that, last year, again, was the first year of 5 years where we had some additional investment that allowed us to invest in general practice that would enable general practice to expand some of their existing estate. As with anything, it is the recurrent revenue consequences of the capital investment that is always challenging. Nevertheless, we are now in a 5-year planning cycle to understand what is coming online when, where do we need to make the investment, and then importantly, we need to work with our general practices because this has a significant impact for general practice in terms of their workforce and them being able to meet the increased demand that will be put on them.
Can I just come back on that point? Because we've got Worcester University running medical courses. When are we picking, are we going in? Are we having conversations of picking out the creme de la creme to invite them to come and join the workforce of the NHS in Worcestershire and the PCN? Because I think the issue is, it's not often about, and I say this when I'm in Bromsgrove, it's not about the tables and the chairs and it's a facility, it's about the person sat behind the desk. And we recognise we're around 30,000 doctors short in the UK currently. How are we going to entice people to train in Worcester but also retain them in the long term? Because that is really fundamental, as I'm sure you're aware.
Yeah, absolutely. Look, recruitment and retention is an issue. It is a real issue across the NHS. It's not just general practice where we have issues with recruitment and retention. And what we try to do locally is, particularly with all of our independent contractor providers, is try and support them in ways that will enable them to recruit additional GPs. Yes, we are working very, very closely with the university in terms of that pipeline of individuals that we may be able to secure locally, because it's always best to have a pipeline and grow your own, in effect, locally, because they're used to the locality, they understand the patient population, and they're able to then, work alongside existing GP practices. But it is a real issue, and Mary or Roy may wish to come in here as a local GP in terms of recruitment issues he's facing.
Yeah, I just, in terms of the Three Counties Medical School, our PCN has students from the medical school, and our GPs are supporting them with their training. So we have students from Birmingham as well, but we're really trying to encourage as many of the local medical students to come on board. So we're and as I say, often building your own resource starts with them as medical students, and then we have them back as registrars, and they're our staff of the future. So I think it's definitely something we look at. Retention of GPs remains an issue. There's still more GPs leaving than are coming in, but the actual recruitment has become easier. You're probably aware there's quite a lot of GPs who are unemployed at the moment. So sadly, there's just not enough posts for the number of GPs out there. But certainly we make full use of it. And as I say, building that future resource is definitely part of our way of working.
Thank you, Roy. Can you build on that, what you've just said, a little bit more, please, about there's a lot of GPs that potentially aren't in a place of work at the moment and would like to. Long story short, I happened to be at the Alexandra Hospital, and one of the consultants said her husband was looking for a GP role. I was quite astounded to hear that when I look about capacity and about many doctors not working a full working week. They choose to do 3 days. And I'm thinking, well, actually, how do you backfill those positions? And can you also give us some evidence about what the largest constraint is to attracting and retaining staff in Worcestershire, please?
So I think there is a shortage of GPs. There was a shortage of GPs a few years ago, so they put lots of extra training posts in. So we've had more GPs coming through. But at the same time, we've had an increase in costs in general practice. We are all still independent businesses, and with a reduction in income. So actually our ability to employ new GPs just hasn't kept up with the demand for appointments. So I could employ 2 new GPs in our practice tomorrow and make sure they're fully used, but we don't have the resource open to us to employ them. So the GPs are out there. I think in Worcestershire it's probably, there's not lots of extra GPs. We've got additional income from our ICB colleagues, so we have a surge hub in each PCN, so that's separate to the national funding. So we have additional ways of employing the GPs, and there's a scheme called the additional roles where we are able to employ them at primary care networks. So we're doing our best to get as many GPs in and as many appointments, but the real constraint is around resource. And that just hasn't really kept pace with the demand over the years.
Okay, I'm coming to you guys 1 second. Just building on this, the reduction of income, where's that? How are you seeing that reduction of income, please?
So in real terms, there's been a persistent reduction in general practice income across the country, at the same time as an increase in workload. So we're probably seeing 20% more appointments than we were pre-COVID, and yet at the same time there's been a reduction in the income coming in terms of real terms because of the inflationary costs and the as I say, the profit that practices rely on is to pay their GPs. So if there's insufficient profit and other costs go up, then we just don't have sufficient resource to employ the GPs. And you mentioned about part-time GPs, which I know can be an issue, but actually if a GP is working 3 days, we can only employ them for 4 or 5 days if we've got the resource to do it. So it comes down to that pool of resource and how we can use it most effectively. Would you say the formula's broken? I think there's certainly issues with the formula. They're looking at it nationally, and there are issues with, there's a thing called the Carhill formula, which calculates how much each general practice gets. That works against deprived practices, which actually, if you're in Redditch or Kidderminster, the need is probably higher, but the resource is lower. So I think there's a national piece of work which hopefully will address that. But I mean, the national contract gives 160 odd pounds for each patient on our lists for unlimited access to appointments. That's less than the cost of one outpatient appointment. So it's how we sort of try and maximise that, you know, our resource around that. So
it's really important, and I am going to open this up now, and I know Councillor Taylor's indicating, but it's really important we address the deprivation rather, because if we don't, then society pays the price here, and it's really, really important that areas like, I think you said Redditch and Kidderminster,
yeah, and
all in the
Worcestershire.
north of the county, all with the opportunity to look at their functioning economic geography to the north. You know, when are we going to expect, can we expect a revised formula that addresses this, please, Roy?
So all GPs are paid via a national payment system. So it's a national contract. So every GP across the country has exactly the same contract. And as Roy said, there is something called a Cahill formula. This was introduced in 2004 and it hasn't been changed since that date. So towards the last 2 quarters of last year, an announcement was made nationally that the Cahill formula would be looked at and be reviewed. Now, I think, you know, we need to understand that even if the Cahill formula is reviewed, there will be winners and losers. So whilst we may support practices who have higher deprivation, if that's how the formula is changed, that will result in funding being taken from other practices. And if we think about when it was introduced in 2004, it took nearly 15 years to eradicate the difference between how GPs were paid prior to 2004 to then equaling it out once the Cahill formula was erased, and there was something called a minimum practice income guarantee that all practices received. So you can see the impact of formula changes, but it is long overdue for review nationally. And we were told that it would be reviewed within a 6-month period, so we're expecting something within Q1 of next financial year.
And this thank you, Charmaine. And this Cahill formula, would that be currently utilised with housing growth, with the forecasted housing growth across the county?
No, what we would do locally is we look at individual practice registered list sizes, and then the Cahill formula adds a weighting based on the perceived needs of the relative needs of those patients. So if you are in a more deprived area, you would get an increase in your Cahill formula. If you had a younger population of maybe university practices, they would probably get less income because that cohort of the population are perceived to need less general medical services need. So that is completely separate to the housing growth formula.
Okay, thank you very much. Councillor Turner, please.
Yes, thank you, Chair. There seems to be some discrepancy as far as I'm aware, and I hope you can enlighten me, because there seems to be this discrepancy between in training doctors, basically a period of approximately 7 years to train a fully qualified doctor as far as I'm aware, but we seem to be having working possibly 3 days a week, or doctors being unemployed, and we're talking about this upscaling and so on. And just trying to understand, there seems to be some discrepancy between if we've got doctors that are unemployed, but then we're bringing doctors from abroad to fill these empty vacancies. Can you sort of enlighten me on what's actually going on here? Because it seems very confusing from where I'm sitting.
Yeah, and look, I can totally understand it. It does seem confusing, doesn't it? I think the issue that we're facing locally is demand for general practice services is increasing year on year. So general practice is seeing about 5.5 million patients each year, 20% more than what practices were seeing pre-COVID. The demand is such that some GPs actually struggle to work 10 full sessions just because of the length of the day and the increased demand on their working day, which is why many GPs have portfolio roles. So which is really good also, because some GPs will work in general practice. They may then also choose to work as part of a hospital role, or they may choose to work in out-of-hours services. So that is an option for GPs to be able to manage their well-being as well as the demand that they're facing. But you're right, I think there is an increase in the number of GPs that are being trained, which is excellent. But when you balance that against what Dr. Williams has just outlined in terms of the running cost pressures as an independent business of a general practice, and them not having the ability and the flexibility and funding to employ additional people, that is really challenging. The other thing I would say is additional roles reimbursement scheme was introduced 5 years ago. Now this offers us a range of about 15 different professions that are aligned to general practice to support with that demand management, because when we go to the practice, not all of us need to see a GP. We're often better managed by other healthcare professionals. Now, the additional roles reimbursement scheme has been a huge success. So certainly across Herefordshire and Worcestershire, we spend in the region of £20 million a year supporting general practice with these additional roles. And that's giving patients increased access also. So I think there's something about a range of healthcare professionals meeting the needs of modern general practice patients.
So it is very hard to upscale, because if we got a period of time when a doctor's in training to fulfill their career going forward, there may be a requirement going forward, or there may be a less of a requirement. So if you're looking to take on a profession like that, that's quite an uncertain pathway to be going, because if any other profession, that wouldn't be the case, because you'd know you'd be fully employed all the time.
I think there are changes afoot, so there are reforms to the national GP contract. So from the 1st of April this year, there is a change in some of the reimbursement that we can give to general practice, and access to a GP is increasing in terms of priority. So there will be an availability of money for each general practice in the country to access to secure additional GP time. Now, historically, that investment was elsewhere in general practice, so it's not new money, but it will give practices now an opportunity to employ GPs if that meets the needs of their patient population better.
So obviously a concern of mine is if we're losing doctors being encouraged to go abroad, that's an absolute devastating resource for our doctors, considering the amount of time it takes to train these doctors. And the only way we can fulfill that gap in the short-term needs is, again, recruiting doctors from abroad. So it seems to be a bit of a vicious circle as far as I can see.
All I would say is the attrition rate is lower than our recruitment rate locally in Herefordshire and Worcestershire, and that is not the case across the country. So that's a real positive in terms of GPs actually wanting to come and work in Herefordshire and Worcestershire and actually stay working locally. That is not, as I say, the case across the country.
Thank you very much indeed. I've got Councillor Satinder Bell, our Cabinet Member for Health and Wellbeing.
Thank you, Chair. Thank you, all three of you, for that report. So my question is, I've got a few questions, but I can just take as we go. So about the appointments, we say we've got 5.5 million appointments for Hereford and Worcestershire. Worcestershire is 610,000, and I'm not aware of how much is Hereford population gets counted into it. And we're looking at 561 appointments per 1,000 patients. Is there any data on practice-wise, for example, you know, how many appointments are delivered per practice? I mean, of course, I've had the chance to visit Starport Medical Centre, which is excellent service, what you're doing there, but that's something standard we look at, and we're talking about here about regions in our county where people are not able to access appointments. And we also say that analysis doesn't really show us the correlation between the attendances in the ED department in the hospital with the GP appointments, whereas I know as a clinician that about 15 to 20% patients coming to ED department are attending because they can't get to their GP currently, but we don't have that correlation reflective here at all.
So thank you. There's a couple of things there. So we do acknowledge there is variation. I think it's always interesting when we try to understand why patients attend EDs, and the message is always because they cannot get an appointment with their local GP. We have done a piece of work locally tracking individual patients so that we follow the patient pathway from them arriving at ED backwards to understand how they arrived there. And sometimes it's not always the case that patients have indeed contacted their general practice to receive an appointment. There's something here about patients being able to manage their own health care and the convenience of some of the services. And for some individuals, taking time off work to go to a GP is really, really costly. And sometimes individuals decide to go to the ED at a time that is convenient to them, which is outside of general practice core hours. So I just think we just need to acknowledge that, because there are variances. The other thing I would say is every single year when we get the National Patient Survey, yes, Herefordshire and Worcestershire are first nationally, but that hides a huge variation in access levels. And what we've started to do this year is look at the lower percentile practices as part of that. And we've introduced a scheme via the peer ambassador role, which is Dr. Williams, and I'll hand to Dr. Williams to talk about this in a moment, to try then and go into individual practices to understand why their access rates are lower than another practice, given that everybody is working to a national contract and a national fee for each patient. And that has actually demonstrated some really helpful results. So I'm going to hand to Roy to talk about that scheme, if I may.
Yeah, thanks, Charmaine. Yes, so in terms of the data, we all have, there's lots and lots of data about appointments, so every practice will have the ability to access, so we and the ICB know how many appointments are being delivered, and you're right, there is variation. So I've got a role as NHS England peer ambassador for our region, which part of my role is supporting practices to understand their data. There's a new NHS England general practice dashboard, and I'm pleased to say that none of the practices in Hereford and Worcester are flagging as a negative outlier on that. There's a few positive outliers, but that's really encouraging. But the data there enables us to work with practices to reflect on their appointments data. And part of it is moving towards the modern general practice model that we run at Stourport, which is largely based on triage. It doesn't have to be online, although online forms a big part of it, and that takes pressure off telephone systems. And but it's a system where you have a clinician basically triaging appointment requests to make sure that the right person gets seen by the patient gets seen by the right person at the right time, and that actually uncovers lots of other sort of issues within the practice that allows you to focus on how can you improve your access, how can you work out when your peak demand is, for example. It's usually Monday morning, but sometimes you have spikes through the week. So the modern general practice model, which is set by NHS England, is really enabling practices to reflect on their access, work out how to be more efficient. Yes, we could do with more GPs, but actually within the resource we've got, how can we use that resource most efficiently, and how can we work out how to try and match our demand as best as we can to match our capacity to the demand coming in. And I think that's something that the practices who are running successfully have really found a benefit in terms of being able to enable better access for patients. And so part of my role is explaining what we've done in Stourport and our other practices in the partnership, and also using some of the national resource to get them to reflect on their data, accepting that it is there's variation, but overall Hereford and Worcester is still doing a really good job.
Thank you very much, Dr. Williams. Councillor Wells, you're on the list next, please.
Chairman, thank you. I don't know where to begin, really, and I'm not going to take more than my allotted couple of moments. I'm reminded of the culture in the NHS when I look at paragraph 22 and the acronyms that we now deal with. So, modern general practice assessment. Progress against NGPA requirements is monitored through the NHS operational planning framework, including capacity and assessment improvement plans delivered by the primary care network, PCN, direct enhanced service. For a layman, that's an awful lot of detail that I don't necessarily understand. What I do understand is the table on the previous page, page 3, top of page 3, where it describes 61% of patients reporting that it was easy to get through the GP practice by telephone. So by definition, 39% said it wasn't easy, unless I'm misreading the data. But it also says that we are 1 out of 42 there. Is that correct? We're ranked 1 out of 42, Chairman.
1 out of 42 ICBs nationally.
So we're top.
We are.
God help the rest. It's a concern, isn't it? It must be a concern to you too. What I find interesting is there's no reference within the report that I can find in terms of online performance data. Yet most GPs seem to have this as an option in accessing services. So I see no data relating to the performance of online. And just before I hand over to you guys for a response, it seems to me that in the years that I've been with a very good doctor's practice, I won't mention it, I have become a customer rather than a patient. That is my perception. And it's a greater responsibility on me personally, and I think you alluded to this a minute ago actually, about patients taking a more proactive role in their healthcare, which is great if you're numerate and literate and confident. But if you fall into a hard-to-reach group, who's looking after them?
Again, that falls with vulnerabilities, and I'd wrap into that broadband connectivity and mobile signal. Since they've switched off 3G, our rural communities are really suffering. Charmaine, please.
Thank you. So I'll try and take each question in turn. So first of all, my apologies for paragraph 22 and the technicalities within that. So this is how nationally NHS England have set the contract for general practice, and modern general practice access was introduced just over 2 years ago, which all general practices across the country were asked to implement. Now that includes online access, it includes face-to-face appointments, people turning up at reception, or people ringing the general practice directly. Nationally, all ICBs are in effect performance managed in line with the operational planning framework. So this is a planning framework that applies to the 42 ICBs that were across the country at that point in time. And that's how the performance of each individual integrated care board is actually assessed. Now, the primary care network directed enhanced service is a contract variation to the core GMS contract. So the core GMS contract is about providing services to patients on a daily basis. 6 years ago, additional services were added to that contract, and that's called a primary care network DES. With that came significant investment, but equally significant workload implications for general practice. So that was that trying to explain. So in answer to your question about there's no evidence here around online access, I think the page on the previous, the table on the previous page actually does address that, because that takes into account all access routes to general practice. So one of the key indicators of modern general practice access, and indeed a contract change from the 1st of October last year, was equity of access for patients, be that telephone, walking in, or online access. And that came into effect on the 1st of October last year, where any patient during the hours of 8 till 6:30, Monday to Friday, could gain access to their practice, and they will be told on that day how they will be managed. Be that you need to book an appointment, or we're going to book an appointment for you, or we will book you into an appointment. So I think, and I hear what you say in terms of, gosh, that means 39% of the rest of the population is not finding it easy to gain access. However, I would draw back to the point that I made at the beginning, is there is variation, and it is that variation that we are now trying to tackle. So it is a fantastic achievement, given the workforce and financial challenges that general practice is facing locally, that Herefordshire and Worcestershire is first nationally. There was an improvement on that position this year, 2025, from the prior year. We were in fact 7th last year. So we were 7th out of 42 ICBs and we were 4th nationally at 56%. So there is a move and an improvement, but there is far more to do, as I've said at the beginning. I think what I would say in terms of some of the outputs of modern general practice, I would draw your attention to Appendix 5 of the paper. And within that, I've tried to demonstrate what changes have we seen as a result of modern general practice access. So things like cloud-based telephony. So every general practice now across Herefordshire and Worcestershire has cloud-based telephony that will enable that callback facility for our patients to avoid patients hanging on the line if there are a number of patients in front of them. And you can see the trajectory of improvement that we've made there from 2023 right the way through to 2025. Equally, I would draw your attention to practice websites. Again, this has been a key area, so we've tried to ensure that there is consistency of approach from all of our practices so that patients are gaining the same information. So again, we've made huge strides there of having that simple to use a website for our practices. Online consultation, you can see in the far right-hand box that January 23 we were at 24,000 online consults. January 24, we're at 85,000 online consults, and that is one of many ways patients can access. That is literally just the online access. And I hear what you say in terms of the rurality of the counties that we're serving and broadband access, and that is a challenge, and it's something we've been trying to work through to understand, are there, I guess, digital inequality for patients not being able to access services online. However, I do know that practices are equally trying hard to support this through their patient participation groups. And particularly, I think things like usage of NHS app. Again, I know it's an online facility, but many of our practices have actually put people in waiting rooms to try and help patients understand how to use the NHS app and what are the benefits to them as an individual of gaining access to NHS services. Roy, from a on the ground delivery, is there anything I've missed?
No, I think it's a really good point about just back to your point about being a sort of feeling like a customer. I think that's unfortunate, and as we see the number of patients per GP sort of increasing, it gets more difficult to manage that family doctor service we want to provide, particularly with a focus on increasing access. Actually, access is one measure of how we perform in general practice, but actually it's not the only measure, but sometimes there's a tendency that everything is about access, but sometimes the quality of general practice isn't all about access. So I think there's just something around there, and as each GP has an increasing number of patients on the list, that gets harder to provide the service that sometimes we want to provide. The phones and moving online, I think I agree about, there are certainly, by moving online, those who are able to are freeing up other ways of accessing services. So I think this is not moving everybody to online, but for those who can use digital tools, actually, for example, our wait in Stourport on the phones has hugely reduced. It's taken time since we moved to total triage, but actually on a Monday morning, we sometimes had 35, 40-minute waits. None of us liked that, wanted that, but it was just the sheer volume of calls coming through. That's now down to, I think our average wait's about 2 minutes, even on Monday mornings. So, and that's because more people are going online, but you don't have to go online. It means that because of the way we've now set our services up, that those who need to phone are able to get through much quicker. So actually the whole thing starts to fold in. And in terms of the inequalities piece that you mentioned, I think we're really conscious of that. Probably more at primary care network levels, so a slightly larger scale, but we are looking constantly at our data of, so for my primary care network covering part of the Wild Forest, we have 73,000 patients. We do lots of work on people who aren't accessing our services, people in deprived areas, people with learning disabilities, mental health issues, and we are reaching out in a different way to those patients, and we're also working to improve digital inclusion. So I think it's trying to do two things really, improving access using digital tools for the majority, but making sure that we don't leave people behind and that we are reaching out in a data-driven way to pick people up who may not be accessing the care. And I think that's the sort of where we're trying to balance that, but that's a slightly different scale.
I think the digital inclusion issue is one that's growing rather than diminishing. And I think as our population grows older and the people are less able and less confident, we've got more people falling through the gaps. Right, I've got Councillor Wells. Did you want to come back before I go to Councillor
Just a quick
Harrison?
one. I wasn't really convinced about your answer about hard to reach groups. I'm not just talking about rurality here. I'm talking about people who, of any age group, of any ethnic background, whatever. What are you doing to reach out to those people? I see the overall number of appointments is increasing. I think I read somewhere in the report, though I can't find it to hand now, where in the last 12 months, out of every 1,000 people registered as patients, over 500 appointments were made. Not necessarily half the people, it could be a quarter of people, twice as much or whatever. So how can you account for the increasing appointments, demand for your services? Is that people taking a greater interest in their own public health, or are these appointments that shouldn't really take place? So what are you dealing with that? And I'm not convinced by your answer about hard to reach groups.
Okay, thank you. So first of all, with regards to hard to reach groups, every general practice, as part of the work they're doing with their primary care network, there is a requirement for all of the practices to work looking at health inequalities. And that is driven by a population health management data set. It will be different for every single practice, recognising the diverse needs of patient populations. Each individual practice will be putting in and have put in place, and I'll hand to Roy to talk about Wire Forest in a minute. They will put in place on how do they manage to actually work with patients who are underserved in underserved communities. So that is happening out there, alongside a whole host of other commissioning responsibilities that the Integrated Care Board is responsible for commissioning outside of the core GP practice, because that is clearly one element only. In terms of the online issue, because of online access, the feedback that I'm getting from many of my GP colleagues is that means that it's lowering the bar for patients to actually contact practices. So patients will be contacting the practice over issues that perhaps they may not have chosen to telephone historically, because it is more convenient now for patients to actually get through the door of a general practice to type a message to say, this is my concern. It is then up to the practice to deal with that. So that is driving increased demand. And I think, we particularly saw that in October of last year when this new contractual requirement came in, where many patients then thought, oh great, we can access via online, but equally that didn't detract from the number of people telephoning. The other thing I would say is it really has helped the online access in terms of how long patients are waiting on the telephone, so that we have really seen that as an outcome as a result of that. Roy, is there anything you'd like to say from a health inequality perspective for your particular PCN?
Yeah, I think, as I say, we're doing lots of work looking at who we might be missing. I think, as you say, if people are motivated and they come to see us and they're having their blood pressure checked or their cholesterol or they're having their needs met, that's great. But we look at data, so we try and identify people, particularly in deprived areas, who haven't been in, haven't had a blood pressure done, may not have had the right sort of physical checks. So there's a whole program of work about reaching out to those people proactively and contacting them. We've also developed new roles within our primary care network. So we have care coordinators. So we are focusing on patients with learning disabilities and reaching out and trying to provide care in a more proactive way to those groups in need. And I think the deprivation feeds a lot of that. And I think looking at our housebound population again, so we've created new services around patients with frailty, so we have home visiting services, but also looking at a much more proactive approach to people who may be living at home, and have social prescribers who are teams that can go out and provide support for loneliness and linking in with other services. So it is a very different approach. I think general practice used to be about the people who came through the door, and I think as we're working now as primary care networks, it's much more us thinking about our population as a whole, who we're not seeing and who we may be leaving behind with some of the access models. So that's that's across across the country, but particularly in Worcestershire, we're really focusing on those hard to reach groups and really conscious of that inequality piece.
Thank you, and it's good to hear that health deprivation and the inequalities is something that's a key agenda item on your agenda, because it's very keen we're very keen to get that addressed, so thank you, Dr. Williams. I'm just conscious of the time, and I've got 1, 2, 3, 4, 5, and both cabinet members would like to speak as well. So can we make the questions as short as possible to get the answers, and can we get as succinct an answer as possible, please, because I want to get as many questions answered. So thank you. So I'll move swiftly to Councillor Harrison, please.
Thank you, Chairman. I'm looking at paragraph 10 of on the general practice activity and associated with the appendices, particularly Appendix 2. So you've increased your number of appointments by 20% over the 2019 figures. Given the background of a shortage of GPs, so how are you delivering additional appointments through the local access initiative schemes, please? Could you tell me something about that?
Yes, certainly. So within the paper, we've talked about the access hub, so the PCN surge capacity. Is that what you're referring to? Yes, so that is a newly commissioned service actually last year, where every PCN has been given additional funding to put on additional appointments to try and help manage some of the demand within general practice. Last year there was a focus on the day demand, so trying to ensure that patients who perhaps really needed to be seen that day by general practice had an outlet if general practice was full, to prevent those patients then ending up in ED. And that is another service. So this is a locally commissioned service. This isn't part of the national contract. That is something that the Integrated Care Board is investing in locally, and has recently agreed to invest in a similar scheme next year, very similar in terms of PCN surge capacity hubs to help overflow activity. Because I think, as Dr. Williams said at the outset, there is an infinite demand, and it's really difficult for general practice to be able to manage the rising demand that's coming through the door on a daily basis.
Can I just come back on that point, Charmaine, very quickly? Have we only got 2 years funding to address this?
Sorry?
You alluded to the fact you've got funding for this year and next year.
Yeah.
What happens beyond that, particularly
Yeah.
with rising numbers of people coming to live in Worcestershire?
Yes, certainly. So this is part of our financial planning process, so it's within our financial plan. So we've certainly at the moment committed it for 2 years. I think what we need to be mindful of is the general practice contract changes on an annual basis. Now, which doesn't help from a planning perspective, because we could commission a service and then it could become part of core practice, and clearly we can't afford to duplicate service provision. But it is something that is within our current financial plan and for the future.
Thank you very much indeed. Councillor Fry, please.
Is there anything
Just a quick one. Thank you very much for your report and what you've said. It seems like a very mixed bag of some good points and some bad points. So, certainly, I do believe that what Councillor Wells said about becoming customers is genuinely happening. When I was born, you really had your family doctor, and you knew your family doctor, and they knew you. That isn't happening so much. I want to go on to the access for GPs as a priority. We can see that in Appendix 1, where we were pre-COVID, what the national is, and where we are now. And it's good to see that we have 20% higher than the 2019 days. How do we, apart from just having a sort of a very brief sort of chart, how do we make sure that we are keeping an eye on this, that we are monitoring it, that we are making sure that we're getting the best out of it, and the people that really need to see a doctor are actually sort of happening? It's clear that the numbers are going up, and that's from a variety of ways, because people can access it, as you've said, in a variety of ways. But how do we keep on top of this, monitor it, and hopefully come up with something to make sure that it's better than what it is now? Thank you.
Thank you. I think there's quite a dilemma, I would say, for general practice currently between the two national priorities of ensuring that patients are seen on the same day where they are clinically urgent, and that's the really important thing around clinically urgent as determined by the practice, versus the responsibility of general practice to manage long-term conditions. And that is the core role, really, of general practice, is to support those patients that are frail, elderly, have multiple long-term conditions, and it's the management of those patients to prevent those patients then ending up in hospital. So there is a real dilemma, I would say, for general practice in managing their capacity to be able to meet both of those, with this added change to the GP contract on the 1st of April of around same-day access. And Roy, is there anything you want to add from a clinical perspective in terms of the management of the long-term conditions versus on the day?
Yeah, I think it is a challenge, as Charmaine says, and one of the things that we are conscious of is that feeling that people are customers, and I think some of that comes down to providing continuity of care, because there are actually lots of people who don't care which GP they see. They want to be treated as customers, so we have this slight dilemma that there's a group of our patients, they're used to Amazon and they actually want very easy access, quick access, rapid responses, and we have to sort of be able to work with those. But we at the same time have to identify where patients who would benefit from continuity and getting an appointment with the doctor that they know, who knows them, and there's huge evidence around that. So we've developed digital systems which will flag to us when a patient messages in whether there's somebody that should have continuity. So based on their underlying conditions, what other health problems they've got, their age, their frailty status, how many times they see a GP generally. And so we will do our best to try and get those people who need continuity to see their usual GP, whilst at the same time providing that easy, rapid access to the people who don't really mind who they see. And it is there's quite a few sort of almost competing factors in that, and we have to try and navigate our way through it. I think some of the way that we use clinical triage through modern general practice facilitates that. So the modern general practice approach is that no matter how people come to us, whether to the desk or phone up or online, we clinically prioritise, and that enables us to try and get a sense of that, actually who should be seeing their usual GP, who can see a nurse practitioner, who could go to our hub in Kidderminster, and that's part of our clinical decision making to try and maximise that continuity of care and to minimise that sense of the people who need that continuity feeling like customers, and I think that's the tricky balance.
Thank you very much indeed. Thank you very much, Councillor Fry. Councillor Harrison, we've covered off, so Councillor McSweeney, please.
Yeah, thank you, Chair. I'm going to try and make this very quick. Just to say, on paragraph 26, it's a comment about same-day urgent access. Significant proportion of patients with remote prior communities, 21% of patients with indices of multiple deprivation 1 to 2. I feel like I'm missing the context to understand that in terms of sort of what that figure means in terms of how that compares to patients coming to GP practice in general and proportion of the population. I'm going to say I'm not expecting an answer to that today. It requires digging into the data. Could we maybe get some context to what that actually means? That was very quick one. I just wanted to kind of otherwise just add in a bit to the general sort of discussion about sort of telephone versus online, and I mean, I very much agree with just like the principles, like the people who don't have access to online, and that's an issue. I thought the comment about lowering the bar, getting more reports, was interesting, but I was just going to sort of make the point that for some people, that lowering of the bar is from not being able to make an appointment for something significant if you've got to phone up to the point where you can, and it's something you actually need to do. And I suppose in terms of the question, it's about sort of actually, I appreciate we're looking at getting GP appointments, but actually the next stage when we go into the GP appointments and actually make sure that for those people who are uncomfortable with using the phone, I mean, if we can do a completely online approach for some things, I will just say I've actually been testing the system. In the pre-meeting, I requested an appointment for something, and I've actually got a response, which is actually, I would say, probably about the most helpful response. I'm actually very pleased with the response I've got while I've been sitting here. It's been, say, completely online, and if we can actually sort of get the broad approach, so obviously those people who want to talk by telephone. Obviously, you're saying we're taking the load off by doing online and actually sort of looking at the whole thing together. I'm not sure if I've asked the question, and my apologies if I haven't, but...
Dr. Williams, Charmaine, or Mary, can one of you?
Can I just come back on the online bit? I mean, you're absolutely right. And as a GP, I'm now having online conversations with patients, and that suits them. What we don't want to do is give the impression that that's the only way to access care, because it's absolutely not. You know, there are some people who are very comfortable and much more comfortable having an online discussion. Some people who want to use the telephone, some people want to come to the desk, and we need to try and accommodate all of those. But by using the digital tools and moving more online, we free up the other channels, and that, I think, is the key to it. And the key message is that with the modern general practice approach, all of those ways of accessing care are dealt with in the same way. So nobody's sort of jumping the queue or beating the system, and I think it's a fair system as well. So
that's good to hear. Thank you very much. I'm going to push it on so I can get as many questions out to you. Councillor Kumar.
Thank you very much for your excellent paper. I just got a very important question on behalf of Bromsgrove. A couple of years ago, myself and Councillor May spoke to Simon Trickett about out-of-hour GP surgery in Bromsgrove. We have a 90,000 population, and we have to go to Redditch. We have a large elderly population. It costs £28 from Bromsgrove to go to Redditch, Alex, and £28 to return. With cost of living crisis, with poverty rising, I put in a case along with Councillor May to Simon Trickett to see if we can set up an out-of-hour surgery in Princess of Wales Hospital. That was then not looked at. But looking at item 40 here, you are looking into neo processes. I think that will help a lot of these people to look into going locally, because a few months ago, when we looked at the acute services, they said too many people are going to A&E in Worcester Acute. Too many people are going to Kidderminster. Too many people are going to Worcester. Why are they going? Because they haven't got a GP access. So perhaps it is time for reassessing and remodeling your contract to see if Bromsgrove is also included in that. There's a 90,000 population. It's not like 5,000. So something to look into, please, because there was such a thing which existed just before pandemic. So I would like to come back on that. I've got one more point after that. Thank you.
Thank you very much. There's 100,600 actually in Bromsgrove District. Sorry. No. I'm just clarifying that. I'm just trying to add to the business case, Councillor. Murray.
Thank you. Yes. I mean, out of hours as part of the 24-hour general practice access service via 111. They do a range of home visits for the frail elderly, because that's what is needed usually out of hours, and telephone contact and support as well. The issue isn't really overnight, it's the weekend, it's the Saturdays and Sundays that is the issue. There's no doubt about it. Now, to supplement that in the interim time, and this isn't ideal, but in both EDs, in the Alex and Worcester, we have GPs, we now commission 12 hours a day, that will take away out of the ED department those walk-in patients that it's a primary care issue. It's not utilised as well as we would hoped, which is an indication there's not as much need as we thought, but it is there and supporting it. The future, though, is neighbourhood health, and I'm sure you've heard about neighbourhood health, and we are talking about how we would deliver neighbourhood health centres in the future. I'm sure Redditch have also put a big bid into us at the moment as well about what they need in Redditch. So we are talking about, in that, what we're calling nationally left shift out of hospital into communities, back where the care should be for the majority of these individuals, developing more neighbourhood health centres. It won't address the whole 24-hour, because there isn't always a need for that 24-hour, but the weekends is something we do need to focus on, definitely. So in our big financial planning and strategic planning for the next 5 years, you'll be hearing more about that to support that. And in places like, Bromsgrove and Redditch and, round Worcester City, they are some of our priority areas for Worcestershire, definitely.
Thank you. So 5 years henceforth, how quickly do you think this could actually come to fruition, please, Murray?
I think that depends on the financial framework that comes with neighbourhood health and our financial planning going forward. We'll have to prioritise, there's no doubt about it. We might have to redirect resources around the system to support this, and that's part of our role as the new strategic commissioners. Not an easy function to do, but we're looking at what Charmaine described earlier, the population health management, the data, the understanding of what is the need in each area of our system, and then putting the services, be it people or capital or buildings, to support that. So we are looking at that closely at the moment.
And we really appreciate that, because I know it's Bromsgrove and it's very close to our heart, but it is a key component with one of the largest housing growth targets in Worcestershire. And above and beyond that, we don't have the bus connection. We don't have that opportunity to get people out of their cars. And it's expensive as well to get across to Redditch, and it's not always the most straightforward of journeys currently with the A38 Brett that's taking place. So mixing all this into the factors that we've got before us, I really do think this needs addressing sooner rather than later. We lost 200 hospital beds when the last proper hospital, other than the community hospital, closed in Bromsgrove. The population's doubled in that time. And I think we are being, and I'm sorry to say this, I think we're being neglected as an area. So I would like to see this brought forward, and I know others will say, well, I'd like my area, but Bromsgrove really is not having its needs met as we see it on the ground. Thank you.
And obviously our responsibility is across the whole patch. We will look at the individual needs and bring that together as a neighbourhood.
I understand that, Mary, but I have to say, with the 200 hospital beds that closed and no out of hours provision, I think it's not acceptable.
Okay, we'll
Thank you.
That, okay.
Right, so very quickly, I want to go to Health Watch as well, Mr Adams, so get ready, please. I've got Councillor Hardman. You sat at the back of the room, but you've indicated you'd like to speak.
Yeah, just very quickly. I just wanted to probe the assertion that lots of GPs are moving to Hereford and Worcestershire because of, it's such an appealing place to work. I'm slightly worried about the demographics, because I remember reading a projection that said that 40% of our GPs were planning to retire within the next 5 years. And are you sure that they're not all lining up their retirement?
Charmaine.
Look, I haven't got because I wouldn't want to give you figures that were not absolutely accurate. What I will do, though, is give a commitment to give you the profile of our GP population across Herefordshire and Worcestershire, importantly Worcestershire.
Thank you. I think that would be really useful if you could. Thank you very much indeed.
Can we make sure the district members get that information as well?
We will disseminate that information, Councillor Fry, across the whole piece, because I think it's really important. Thank you. I've got Simon Adams from Health Watch. He'd like to speak. I've got Backle, who's got a supplementary question, and I've got Councillor Bell, Councillor Eacock. Councillor Price, has your question been answered? No. Okay. Right, so we're going to have to be quick here, succinct with the questions, please. Simon.
We don't have a lot to say, to be quite honest with you, other than to say that, for a long time, we've always said that when we talk to our colleagues from across the country, although we obviously do get calls about GP services, we actually find that our GP services function a lot better than the others across the country seem to, and also a lot better structured. I think we're lucky to have big GP practices, or what are seen as to be big GP practices, as opposed to small GP practices, which might only have, say, 1 or 2 GPs in them. The only question I'd have about the data, and we're nice to hear we're now top of the GP survey, is that because the others have gone backwards that's enabled us to come top?
Charmaine's shaking her head.
Or is it because we've had significant step changes in
There was an overall increase across the country actually last year, and I would put that down largely to the implementation of modern general practice access and the increase in access routes for our patients.
Thank you very much indeed.
Yeah. And just one last comment, and that would be to say that when we looked at it very carefully last year, we saw that although, there is a mixed picture across Worcestershire, you have to look at it carefully, because the surgery that was the worst for people to be able to get an appointment was actually then rated as one of the best surgeries for the quality of the appointment when it took place. So you do have to look right across all of the data before jumping to conclusions.
Thank you very much. That's a very fair comment. Thank you. So we've got Councillor Hardman, you've answered your question. Councillor Bell, Councillor Eacock and Councillor Price with quick questions, please.
Thank you, Chair. My question is about, I'll just take you down to, although I want to mention just about some of the comments which I think afraid I don't agree with. For example, patients going to urgent care, emergency or acute services, or patient, overusing online system just because it's available. I think that's one aspect, but the percentage is very, very low on that. And same for urgent care, that people can't go to the GP because they are working during the daytime. But I think my perspective is people don't have to redesign their life because their GP is not working during out of hours. I think we should not be, we need to be honest talking about that. In 2005, when the government changed the contract for out of hours for GP, and that was the worst thing done from patient perspective. So just urgent and emergency care, these 200 patients per month redirected into primary care, is that from the GP activity in the ED, or is it, so that's about 31, supporting urgent and emergency care? Because if it is across Worcestershire, 200 patients per month, that's actually not a lot, isn't it? Is that from GP activity?
Yeah, it's from redirection back to our single point of access, either from the ED or the professionals. Now, this is a fairly new thing, so we want to see more numbers going back to this. We're encouraging our GPs, our ED colleagues, that if a patient comes that is really primary care and doesn't need to be seen in an accident and emergency department, which is for accidents and emergencies, redirect them back to primary care, get them booked into those same day urgent access hubs that we've talked about. So that number is growing, but it's not where we need it to be at the moment.
I mean, that's an issue of duplication of work for GPs as well, isn't it, which could be used better for value for money. The other one is Worcestershire GP out of hour service. So there's no number that this contract, whoever was doing Practice Plus or Care UK, how many patients have they been seeing year to year in this contract? Is that being monitored? Because that's not mentioned here.
Yeah. Okay, so we haven't, I don't think we've got the detail. Have we got the detail of the out of hours? Yeah, out of hours. It has been going up. I know it's been going up considerably because we've just awarded the contract back to Practice Plus Group again, so they are their contract holder. And you can see on Appendix 6 how many contacts they've seen. Some of it is in visits. That is sort of stayed about the same. Some of it is in their centres. That has gone up. It did when COVID happened. It seemed to stop those visits into the centres around the county. That has started to go up again. And some of it is virtual advice. That stayed about roughly the same. 111, NHS 111, who is the access to out of hours, and they will redirect to other services as well. So that has changed the whole profile of the urgent care system. Whether we agree with 111 or not, it has changed the profile.
I'm lead for urgent care. So I've designed urgent care service and 111, so I work with them, so I know that. But having said that,
I just interrupt you 1 minute? Simon Adams has just indicated he'd like to speak. Simon, did you want to come in at this point, please?
If I could, because it is on this point, and I'll just pick it up on Mary's redirection from ED to primary care for patients who are presenting ED but don't need to be there. I'm just, at the back of my mind, I've got this issue that when we went into ED to ask patients why they'd actually turned up at ED, 70% of the patients we spoke to had all been sent there by some other part of the NHS. And we've asked the Trust for a long time to give us some real data from ED about, okay, it's very easy to make the decision that the patient doesn't need to be there once you've triaged them. So is that a comment that's being made with the benefit of hindsight? This is the first thing. And the second thing is, we would not want to see patients who have been told to go to ED by NHS 111, for example, then being told you don't need to be here, you need to go somewhere else. Because that's not going to do them or the NHS any good, is it?
Thanks, Simon. Murray's going to pick it up. Thank you.
Thank you. And Simon, we've spent the last year redesigning all of this. So 111 now come into our single point of access. It's outside of the ED to access the appropriate out-of-hospital service. That is fairly new as well, so that's just growing and is stopping those patients that really shouldn't be going from 111 into the ED. So we have seen a slight improvement in that, but it needs to grow even more. But there are still there is other agencies that send people into ED, and sometimes in our audits we know that's not the correct place for them. So we are working with those agencies to address that. Care homes being one of them at the moment that we're working hard with in supporting them. But there are still a cohort of patients that are walking into the ED, and if it really is not something that should be dealt with in an accident emergency department, we are encouraging them to go back to primary care, and we're going to use some technology to get that appointment back into primary care as soon as possible. That's quite new, and it's trying to educate the public this is the right thing to do if they've just accessed it without trying to try primary care first.
Thank you very much, Mari. Just conscious of time, Councillor Bell, I know you've had a couple of questions. Is it a very quick one, please?
Just want to say that same for Bromsgrove. I mean, these people, it's not about cost of living crisis. These people deserve that care, isn't it? They're paid in the system for God knows how many years taxes. They deserve medical care. And same for increasing attendance. If you look at our population, it's not grown in Worcestershire for last 10 years to be reflecting that on the attendance. It's more, population is much more sicker now. That's the reason they are attending, and aging population and all the issues with that.
Thank you very much. Hold that thought because I'll be coming to see you. Councillor Sue Eacott, please.
Thank you, Chair. Thank you for your report. I'm actually from Redditch, so I know the hospital. I was in there a few weeks ago for a minor injury, and the waiting room was absolutely full of patients that shouldn't have been there. But they got no access to doctor's appointments, or they couldn't use the app. It's the app that concerns me, because I visit a lot of vulnerable, elderly, and also ethnic people who can't use the app. They have no idea. Their landline's been taken away from them, well, because obviously it's all changed. And they struggle to make appointments. I myself made a flu appointment through the app last year, turned up and it hadn't registered. So I had to have another appointment, which was all right, was fine for me. But somebody who's desperate, who books an appointment on the app and then shows up and the appointment's not registered, isn't really very convenient, for, especially if they're elderly. So I just think that if there was some easier way for elderly, vulnerable people to use that app, or if they could just phone the doctors and be put through. It is a problem, and as I say, when I went to the out of the hospital, it was full of people who said, I can't get through on the app, I can't get an appointment. So,
thank you very much. I think, Charmaine, can you answer?
Yes, I was just going to say, the NHS app is one mode of access only. It is not the only access mode. So telephone, walking into your GP practice, or online are the other access modes. So for people who are not able to manage appointments digitally, there is always the opportunity to either telephone or walk into your general practice to manage your care.
Walking works if you can, not walking out. Walking works if you can. Because I use walking.
And can you use the mics, please, just in case, because people at home.
Walk in works if you can, certainly, yeah. I use walk-in services because I realise it's difficult doing the telephone because you are waiting a long time, and it's difficult using the app because it's not always reliable as it should be. But walk-in, it works if you can get there.
Thank you very much indeed. Simon Adams from Health Watch has indicated again.
I just wanted to say, just for the sake of clarity, we talk about making appointments. As far as I'm aware, you cannot make an appointment in Worcestershire on the NHS app. You can't make an appointment. You can actually, or through your doctor's website, you can actually ask a question which might invite them to give you an appointment, but you can't. And Tom, the comms man, is sat over there, and we had a discussion about this. But just for the sake of clarity for public, right, you can't, as far as I'm aware, you can't at this moment in time actually make an appointment through the app. You can ask a question, you can ask for an appointment, but you can't make one.
Thank you for that clarification.
We'd like to get to the point where, of course, you can look at the diary and make an appointment for a routine issue. rather than being summoned in the same day that you actually make your inquiry.
I think that's a really good point you've raised. I think, Tom, as part of this, Tom Grove at the back, if we could have confirmation of how you actually work your way around the system, or work with the system, should we say, at the end of this, I think that's one of the actions we should take for clarification. All right, if you don't mind, please. Thank you. Okay, Councillor Price, Councillor Kumar and Councillor Turner, and then we'll move on to the next agenda item. Thank you.
Thank you, Chair. The questions regarding the contract, because we've mentioned that we've awarded said contract. The question is, so what improvements have been procured within the new contract to improve patient experience?
Thank you. As part of the contract has a lot of variables in it. Obviously, we're always seeking improvements in access, improvement in quality outcomes. But one of the key things we're doing is trying to address the urgent care issue at the moment. So we have linked our out-of-hours contract to our new single point of access, which does the coordination of all the services out of hospital and some of the ones into hospital as well. We've got one point of contact to make sure patients get to the right place for the right care. So the out of hours is now linked into that. We will have a practitioner from that into the single point of access. That's new. Once that starts, I believe in July, that's going to start. That will help to link that 24-hour approach to care as well. Okay.
Thank you very much indeed. Councillor Kumar.
Thank you, Chair. Just a two-part, a small question. What percentage of patients in Worcestershire currently wait for more than 14 weeks to get a GP appointment? And based on the newly introduced Jess's rule, how many things what is happening with regards to GP surgeries regarding referrals to the primary care centre and missing out on diagnosis of cancer and acute exacerbation of chronic illnesses? Thank you.
So thank you. I'll pass to Dr. Williams in terms of Jess's rule, because I think it's important that you understand the how it's managed on the ground. In terms of GP appointments, so every single month there is a whole host of metrics that the ICB manage in terms of understanding how general practice is managing appointments. So I think if I say to you that in terms of over half of all appointments are face-to-face, 52% of patients booking an appointment are seen within 1 day. So that's 52%. 90% of patients have an appointment booked within 2 weeks.
Thank you very much indeed, Charmaine. Councillor Turner. Oh, sorry.
Come back about Jess's rule. The Jess's rule, although the rule's new, actually, most practices in Worcestershire have had very similar processes already. So in our PCN, we have a 3 strikes and rethink. So I think those processes about just reconsidering diagnoses and escalating. We have very heavy use of the advice and guidance system, so we can ask consultants for advice. We refer appropriately. We have very supportive colleagues in secondary care, and I think that sort of connection, there is data that we look at about the number of emergency admissions with cancer, and that's certainly, we're not an outlier on that by any means. So I think there's no sort of sign that it's an issue, and I think the Jess's rule will be embedded, but I think is actually already happening in most practices.
That's certainly very good news. Thank you. Councillor Turner, please.
Yes, thank you, Chair. With different ways of accessing appointments and so on, we spoke quite a lot about online, so on, and getting access. Certain other industries, they've taken away that facility because they find that they can get overwhelmed because people are constantly feeding them online, and then you become snowed under by the thing that you're actually trying to fix. Rather than probably through a telephone appointment, that inquiry could be dealt with quite quickly. But the main point I wanted to make is what we've already briefly discussed is provision for out-of-hour appointments. My family, for instance, they're all working professionals. They're all working from about 8 o'clock until gone 5. And I don't know what you want to consider them. It may be a mild ailment they may have, I don't know, an eye problem or something like that, but they still need to go to work, but they still need access to a doctor's appointment. And that may be quite a serious problem, upset stomach, whatever it might be, but they can't take a day off. They can't take time from work because they're going to you'll be penalised financially. So we need to have more provision for out-of-hour appointments. Thank you.
Thank you. So as part of the primary care network contract, there is a contract with every general practice and PCN across Worcestershire for enhanced access. And that allows patients to be seen up to 8 p.m. in the evening. Now, every primary care network across Worcestershire has a range of appointments that are available to their patients, and you will be able to find details of this by contacting the practice, because there are appointments available either before the surgery opens, so outside of the 8 a.m, or after the surgery closes at 6:30 p.m. And many of our practices are actually managing demand via that enhanced access route.
Thank you very much indeed. I think that concludes all the questions. We've had a real in-depth discussion there, and I'm very grateful for your contributions this afternoon and for your time. Thank you very much. The actions that I've got on my list, and members of the panel, if you'd like to add to this, is provide the profile of the GP population to HOSC and provide information to how to make GP appointments out of hours in particular, that mechanism to how you get to where you need to get to in the shortest route without impacting on the greater NHS. Anything else you wish to add to that? No, thank you very much. We'll move on to oral health. Thank you. Thank you so much, Dr. Williams. Really appreciate your attendance. So I'm going to start with Health Watch this time. Oral health. Simon Adams, have you got anything that you wish to raise at the top of this agenda item, please?
We haven't, to be quite honest with you. I've got to say, I think we've had some calls about access in the last quarter, but not the issues raised that we normally would have had. So I think maybe the investment and the work that Charmaine's been doing with colleagues might be paying off. Charmaine?
That's excellent. It's music to our ears. Thank you very much, Charmaine.
We're starting to see green shoots, I will certainly say that. It's like any new commission service, there is a period of time by which this takes to onboard, but we are certainly seeing increasing in access to dental provision for our patients across Worcestershire. And hopefully the report outlines some of the key areas where we've seen. But over the last 12 months, we have commissioned services for an additional 27,000 patients to gain access. Now, this isn't something that we are stopping at just because we've commissioned 27,000. We've got a lot more to do. However, what I'm really pleased with is the response from the profession, because there has been a decline in NHS dentistry, as we all know, over the past 10 to 12 years. Through the delegation of these services to the Integrated Care Board in 2023, we have re-engaged with the profession. We have really good relationships. We're listening to what they're saying in terms of the needs that we need to address as commissioners. And that is outlined within my report in terms of some of the dental recovery plan actions that we have taken to increase access to NHS dentistry.
Thank you very much indeed, Charmaine. This is a really good report as well, and it really does highlight the fact that you are being very proactive on this front, so we're most grateful for that. Questions from the panel, please. Councillor Turner, please.
Yes, I've heard various stories that trying to get an NHS dentist is proving quite difficult, and it's not worthwhile for practitioners to take on NHS dentists patients because it's not financially prudent to do so, and wonder what could be done to address that problem.
Yes, you're absolutely right. So when I came to speak to members February of last year, we were in a very different place, I would say. So we were bottom in the West Midlands for access. We have increased 3 places, which is pleasing, across the number of the 12 ICBs. However, we've got more to do. You're right. Again, dental practices are commissioned via a national contract. And there has been no reform to that contract, or very limited reform to that contract since 2006 when it was actually implemented. And GDPs, so general dental practices, are actually rewarded based on units of dental activity. So the more activity they see, that will manage against their contract. So every single practice has a set number of units of dental activity. what we're finding is many practices are seeing the patients that are having less complex needs because the contract does not reward them for seeing patients with complex needs. So the current payment mechanism nationally for dentists, if I turned into a dental practice today and I was seen with my checkup and I didn't need any treatment, the payment that the practice would get would be the same as a patient coming through the door that actually who needed 2 or 3 fillings. Now, the time spent with that patient is very, very different, which is why we're seeing large numbers of practices leaving the NHS. However, what I will say in Herefordshire and Worcestershire is we have not seen any practices leave the NHS since 2023. So just before we took on the contract in 2023, March 2023, there was a number of practices handed back contracts. What we've tried to do to try and I guess, counteract the national contract is put in place local flexibilities. So we have taken a decision locally to increase the unit dental activity cost to each of our practices. There is a national sum, however, we've gone above and beyond that with our local investment. We pay just over £33 per unit of dental activity. That has resulted in the market stimulation, so we have seen new practices open, and you can see we've opened 2 new practices in Herefordshire, but equally we've commissioned nearly 30,000 units of dental activity in Worcestershire through either existing practices who are now willing to provide NHS services or through flexible commissioning arrangements where we're able to support our current NHS providers. But nevertheless, a complete reform of the overall contract is due. I have outlined in the paper there are reforms due from the 1st of April. We received an update on that last night, where there is a staged implementation recognising that actually practices need to be rewarded for the more complex patients, so that will support our practices. Equally, there is a change in terms of supporting practices with things like appraisals, because they're currently not supported. So it's more of that workforce retention that's coming into the practice, which is really helpful, I think, in terms of trying to retain NHS providers.
Did you want to come back with a supplementary, Councillor?
Yeah, so potentially some of these patients that have got more complex needs, so rather than going for regular appointments, they're going when they're got severe toothache or abstractions or something like that. So it's more complex needs. So they're finding that less and less practices are willing to take on these patients. So that's basically what the problem is. So if you're altering the contract, so you're paying them on for what work they are doing, then they're prepared to take on that client.
That's correct. So from the 1st of April, a new complex care pathway will be introduced. It's a phased approach, so it's likely to come online from June. Nevertheless, it's in the contract, which is the first time that we've seen that ever. So it's really, really positive for our patients because then they will be able to gain access. In terms of the urgent dental access, the other thing I would say is from the 1st of April, every single dental practice will be required to put aside 8% of their units of dental activity to allow patients to access urgent dental care. Now, some patients will want to access just take them out of pain. They do not want to have any continued treatment. But equally, there will be a large cohort of patients that do want continued prevention and treatment, and we now have that facility to support that as part of the contract.
I want to briefly come back. Do you think it's because they perceive there's going to be a financial cost as far as continued? Because I can't imagine why you wouldn't want to keep going back to have continued treatment. You must perceive there's going to be either pain involved, financially or physical.
Yes, absolutely. So there is a cost, isn't there, to us as NHS patients for any treatment that we receive. So there is a cost implication. There is also a time implication for some people. You mentioned some people can't access GP appointments during the working day. It's very similar in terms of dental practices. So there would be that prohibitive factor for some individuals why they don't wish to have continued prevention.
Thank you very much indeed. Any further questions on this, please? Councillor McSweeney, please.
Yeah, thank you, Chair. There was a brief clarification on information on section or page 15 of our notes under section B workforce section 3. We're talking about here about foundation training here, and says there's been a notable improvement. Worcestershire now has 11 foundation training practices, representing a significant increase from 8. I was just wondering, is there any information on location? I think we're conscious that obviously there's geographical differences in terms of sort of all things, and I was kind of just curious about that particular one. I mean, I think otherwise, it was interesting actually sort of kind of following on from what was just said about fundamentally sort of people coming into urgent dental care and actually sort of whether people wanted to carry on treatment. And I'm sort of thinking about the spend to save and sort of like actually looking at the whole perspective, whether there is any sort of initiative to, I mean, I appreciate what you say that people don't want to, but in terms of encouragement and coming into the whole educational aspect, I mean, is this slightly, I understand, outside the scope of what we're talking about here, but it feels like this is the whole approach, looking at that sort of getting people to have the dental care and sort of actually getting the treatment in place. And yeah, thank you.
Thank you. So yes, so it's a real success story actually that we've gone from 8 training practices locally to 11, and I think that's reflective of some of the actions that we've put in place through the dental recovery plan, particularly around supporting recruitment and retention of staff. They're fairly evenly spread actually across Worcestershire, but I can certainly give you a map of where those practices are outside of this meeting. In terms of the prevention, so prevention is absolutely critical here for dental care. And again, as part of the contract reforms from the 1st of April, there is a new contract element for enabling fluoride varnish and fissure sealant to be applied for children's teeth. So really getting in early and starting that prevention journey before they reach adulthood, where some of the perhaps decay has happened where they haven't had access previously. Equally, you will have seen, I think, from our report, there has been quite an increase in terms of the number of children that are accessing dental services. So again, I think that's really positive. So 35% of the population nationally accesses services. We have 37. 60% of our child population actually has access to NHS dental care versus 58% nationally. So we are tracking slightly above. However, there's more work to do, as we always say, and we would like that number to be higher.
And I think we've got to pay tribute to Anna Hunt, who is the specialist consultant in dental public health. She's done an awful lot of work in this area to attract and make sure that we get investment in the right areas, hasn't she, Charmaine?
Oh, absolutely. So Anna has been instrumental in the dental services equity audit that she has published for us as a commissioner, which has then driven our commissioning policies so that we're really targeting the areas of high deprivation needs, and particularly the deprivation IMD 1 and 2. We're really focusing, so we've put in place in the last 12 months a dental inequity premium, where in practices in those areas that are willing to take on more NHS patients, we are actually increasing their unit of dental activity rate in recognition of the additional workload that this patient population drives.
Thank you very much indeed. Can I ask a question myself first before I move over to Councillor Kumar? Bromsgrove, Redditch and Wychavon have fluoride in the water. What's stopping us from introducing it into the rest of the county?
Really good question, and we talked about this last year actually. So this is out with the remit and due restriction of us. However, I think it's all of our roles to try and promote fluoridisation. So the council have a key part to play here, but it's not within our gift to do that. I think the changes to the national contract around fluoride varnish for children will help, because I think that again is causing some of the decay issues that we're seeing in terms of the decayed, missing and filled teeth ratio that we have locally. So it is an area that I think we need to continue discussing, and the appropriateness of fluoridisation in the water.
So do we carry on doing extensive tests around areas that do have fluoride in the water vis-a-vis those that don't? And what data have we got? Where does the actual outcome of the argument sit really, Charmaine?
So the public health, so our consultant in public health will be able to give us all of this evidence, and Lisa will certainly have all the data on this for us.
I think it's a piece of work I need to talk to the Director of Public Health and the Cabinet member about. Yes, of course you can, Councillor McSweeney.
Yeah, thank you. I mean, I think sort of kind of prompted by discussion. I did my research since we mentioned this just a bit earlier, but I've got something sitting in front of me here. I've just picked one figure here. UK review in 2000 found evidence of water fluoridation reduced caries prevalence. Increased the number of caries-free children by 14.6%. I mean, I'm just taking one data point. It also says further down here about side effects, and there is no evidence of the side effects that people claim for. I'm just giving it.
Okay, thank you very much. So I think you said 14.6 reduction in areas that have fluoride in the water. Yeah. Thank you very much. Okay, hold on to that statistic. We'll have that further conversation and maybe put it on the work programme about the conversation with the Director of Public Health about where we go with fluoridisation. Councillor Kumar, you're next, please.
Thank you, Chair. Just got a question about the geography. Which districts currently have the lowest NHS dental access rate? And then what's happening about children? You did talk about children, but has the child uptake on dental care improved since the local dental recovery plan? You said 60%. Has it gone much more than you expected or lower than you expected? Thank you.
Thank you. So in terms of the population increase, we've seen a 2% increase in both adults and children, which is in the last 12 months. I think I said at the outset, we're very early days in terms of commissioning. Now, these figures are run on a 12-monthly basis, so it will be interesting to see the next level data set to understand how we benchmark nationally and both regionally in terms of child access rates. However, it is a key priority for us in our commissioning arrangements locally. In terms of the dental need, so this is driven, as I say, by the Dental Services Equity Audit, and contained within your paper there is a map that details it's figure 5 within your papers, and it details the areas, the 176 wards, and the 48 of those we have been identified as a high priority for us to commission additional activity. What we're currently doing is working our way through in terms of the highest need first. Now, if we think about the budget that NHS England has given us as an integrated care board, it's just over £7 million. We commit that budget fully on an annual basis. Historically, prior to 2024, there was no commissioner right to rebase any contract. So we could have had a contract that historically had, for ease, a £100 contract for 10 UDAs. They could continue having that contract and actually committing no NHS service provision at all, and we would give them the contract again. The changes in the national regulations mean that if a provider underperforms for 3 consecutive years, we can rebase that contract. That then enables us as a commissioner to reinvest that money. So the 27,000 units of dental activity that I talked about earlier, that's through largely reinvestment of money that had previously been sat in contracts where no NHS activity was delivered. So as we move through every single year, we will be reinvesting and working our way through those high priority areas.
Thank you very much. Do you have a supplementary question at all, Buckle? Thank you very much. Councillor Turner has a question, then Councillor Bell, please.
Yes, thank you, Chair. These varnish applications that you mentioned for young children is a bit like saying driving your motorcycle with a crash helmet on, rather than shouldn't we be telling them to drive more carefully? So the point really I'm trying to make is all about prevention. And if you're not teaching children at a young age to take care of their oral health, then if you're not doing that, it's not going to follow on as they grow older. So if you teach them at a very early age the proper way with fluoride, toothpaste and so on and so forth, TPs and all of the floss mechanisms, that will stay with you for life and that oral health will continue. That's the way that I think we should be doing, so people are taking control of their own oral health.
You're absolutely right. Look, prevention is a multi-stranded approach, isn't it? It's not a one-size-fits-all. What we're trying to do collectively with local authority colleagues, because oral health improvement is a commissioning responsibility of the council, we work hand in hand with our colleagues in the council around longer term prevention versus early years prevention. So there's all sorts of schemes that currently our council colleagues are commissioning through early years intervention, supervised toothbrushing, equally fluoride varnish has been a scheme locally for many years. So this isn't a one size fits all. I think what we as an integrated care board have to do is ensure that there is ongoing prevention and treatment available for NHS patients. Because historically there just hasn't been that access route for people. And people have been forced to pay privately to access services.
And just to back that up, so you know, that there have been 36 educational and early settings across Worcestershire have so far received oral health improvement support and are actively delivering supervised toothbrushing to the children, with 654 children participating as of the end of December 2025. There were 13 quality assurance visits completed and 20 nurseries receiving oral health improvement refresher training. So work is ongoing.
When you have such as the campaign we tried to stop smoking, and you look at the back of it, I've never smoked in my life, but you only have to look at the back of a pack of cigarettes and it would absolutely frighten you to death. If you imagine a young child, you don't have to give them graphic details, but this ultimately, if you don't take care of your teeth, this is what you could look like when you're my age.
Yeah, I take your point. Yeah, I do take your point. It is looking after you. I smile because I quite often say to family members, I don't want to drop and go, I want to keep them in my mouth. So, yeah, I think it is important. But the education piece, joking apart, is really, really important. And early prevention. Making it part of a daily way of life. And they actually recommend brushing your teeth 3 times a day now. I don't know, that was the latest thing I heard on the radio, from twice a day. And apparently you're meant to stand on one leg to do so because it encourages your core to be stronger as well.
Well, I brush my teeth after every meal I have, so...
No, but it's good practice, Councillor. Councillor Bell, please.
Thank you, Chair. I must say that ICB has done, you've been doing a lot of work on to improve the dental services, and we all know they have been in decline for some time. I can see from this report that you're incentivizing, you've been providing all sorts of incentives, but you're not getting much in return as far as delivery of service is concerned. Of course, the first point is foundation doctors. So foundation doctors train there in a practice for 2 years and then they leave to go and do private practice. So there has to be something to, they need to have some sort of contract to serve in NHS for a number of years before they actually go out to do private, so that work is delivered. The other thing which I was looking at is about, of course, we are working from public health point of view. I have had the chance to go and see a toothbrushing campaign in a school, so which the teachers are doing a lot, council is doing a lot, and they're trying to educate the families as well. But there's not much campaigning going on from the practices side, as like we do from the GP side. So, the GP practices are doing a lot. Because when we talk about the medical practice compared dental work is all about prevention, and here there is a catch-22. So they are not seeing you to do their majority of work, which is preventative work to keep your teeth healthy, and then it becomes a complex problem. Then they're not going to see you anyway. So how you deal with it, and I understand contract issue is one thing. I've actually had a nightmare last night that I lost my teeth. I'm not sure is it just because of this meeting or the struggle in dental services we have. So there is a contract issue, but there is another issue, that the way this whole service is designed is not patient friendly at all.
Okay, so that's a multi-stranded questions you have there, so I'm going to try and remember them, but forgive me if I don't, and please do come back. So in terms of outcomes for incentivization, I think I'd probably ask colleagues to look at point 27 in terms of the report, in terms of what have we delivered so far. So since we became a commissioner just over 2 years ago, we've opened 2 new NHS dental practices in Herefordshire, first 2 NHS dental practices to be opened since 2007. That provides 18,500 units of dental activity, increasing access for patients, for 12,000 patients in an area that was historically deemed a dental desert. The other issue I draw members' attention to is in terms of the inequity premium. So this is a new service that we've commissioned, and I think that's really about addressing high levels of deprivation, and that's where we focus some of our investment. So again, we've created there appointments for nearly 7,000 patients in terms of commissioning of inequity premiums. The other issue I would draw members to is the dispersal. So we have been able to rebase our contracts and then reinvest that back into NHS dental services. We have therefore created nearly 7,000 additional appointments for our patients. Sitting alongside that, we've also, at the 1st of April of this current financial year, commissioned nearly 13,000 urgent dental appointments for patients. So, I will go back to, yes, there is more to be done, but we are seeing an increase. As a result of that investment, we have therefore seen an increase in the number of practices in Herefordshire and Worcestershire actually accepting NHS patients. So we have moved from 37% in September of last year to 55% in January of this year. Now that is a significant increase in the number of practices taking on NHS patients. That now places us 13% above the national average of NHS practices accepting patients locally across Herefordshire and Worcestershire. And I'd go back to the way the national contract is driven. The general dental practices are not able to survive solely on the NHS dental contract. So there will always be a mix of NHS and private provision. And equally, as a NHS patient, there will be elements of my care that will need to be provided under a private arrangement because the NHS doesn't offer that. So there is a place for both. What we're trying to do locally is increase that NHS provision. What was your final point? I'm sorry.
Foundation doctors leaving the practice after 2 years because they're not even that
Yes.
senior after 2 years.
No, you're absolutely right.
Become dentists,
Yeah.
like proper dentists.
So as part of our baseline assessment in developing our dental recovery plan, we spoke to many of our training practices who said that actually many of the foundation dentists leave immediately the NHS as soon as they're qualified because of the potential earnings from private is far greater than NHS. However, as part of the dental reforms that are being consulted, that were consulted upon last summer, there will be a requirement moving forward for dentists to remain in the NHS for a set number of years, which is a real benefit for our patients because then it will give us a greater pool of NHS provision before people are able to move to private dentistry.
Thank you very much indeed, Charmaine. Councillor Kumar.
I think taking on Councillor Bell's point forward, I think prevention is only being taught in the preventative manner in the schools, etc. But dental practices send you text after text. Do you want the teeth getting clean? Do you want fillers put in, etc., etc.? I think part of this contract also should say, can you send messages out to say about dental hygiene for children? Because that is preventative. The more you attack, the better the outcomes are. So not only restorative dentistry, but preventative dentistry will also help if the new contract says you must also not only do restorative, but also preventative dentistry. Okay, they may not get money for that, but it is a part of the contract. Thank you.
Thank you very much. I think that's just for noting, isn't it? Thank you. Thank you, Charmaine. Councillor Turner, please.
Yeah, I wonder if you just can reassure me that no unnecessary work or could possibly be done or abused within the system and charged for as a consequence. Can patients, residents be reassured that is not a possibility?
So that would be down to every single individual dental practitioner and their clinical skill set and what they're offering their patient. But what I would say is, as part of an NHS course of treatment, there is a treatment plan, and as a patient, you you can sign off that treatment plan. So when I go and have my checkup with my practitioner, I am then told you need X, Y, and Z. And then it's up for me to say, yes, I accept that treatment plan. Patients don't have to accept it. However, I take on board that actually as a patient, you will take the advice of a clinician. What I would say though is if you are doubting that, if patients are doubting that, then seek second opinion to see whether or not you do actually need that treatment plan that has been suggested.
Yeah, I understand, but you imagine you have a professional stood in front of you. I'm just asking the question. It's a legitimate point that I'm sure it must have happened somewhere, that treatment has been taken place when potentially that treatment wasn't needed, and when you've had invasive fillings done. I mean, I'm a child from the 70s, and when I go to see the dentist now, they call it the heavy metal brigade. So was that strictly necessary in that period of time?
Yeah.
Could it still be happening?
Yeah, and look, each dental practitioner is subject to professional code of conduct and their clinical standards. So if there was any scope of this happening, then there is an opportunity for patients to report to that individual practitioner, but they do have a conduct in terms of their profession and their standard of care.
Thank you very much indeed. Councillor Fordington, please.
Well, the simplicity of this whole thing is the costs. That's the reason why this is all the way people feel about this whole sort of mix. Of course, when you go to the dentist, the first thing you're looking at is what's going to be the bill at the end of your services. And that's where the bottom line is, because you go there, as what I agree with Councillor Turner, that it is about not knowing what you're going to be needing, because obviously you can't see what's going on inside. So I feel it's about the cost, and how can there be a care plan to put forward with these costs itself?
So the NHS has a cost structure. So there are 3 bandings at which each individual patient would fall into, bands 1, 2 and 3, and the cost range of that goes from £27.40 for a checkup right the way up to £326 if patients are having dentures or bridges, the more really complex work. So each episode of care that we have will fall into one of those bands of treatment. And of course there are some exemptions for patients in terms of not being able to pay the NHS banding charge.
Thank you very much indeed. I can see, Councillor McSweeney, please.
Yeah, sorry, I just wanted to come in again on the geographical issue. I mean, I know that we've got a map here which is of the dental need. I mean, we're talking about sort of new placements, new dental practices in Hereford, and you identify other locations, Bromsgrove, Redditch, Kidderminster, Stourport and Bewdley. So it's a question of, so we have other locations identified for dental need outside that. I mean, I'll say including the area I represent, Malvern, but there are others as well. That are we getting new dental practices, appointments in those locations when we have need?
Yes, so as I try to outline it's about investment of funding. So we have a set budget of just over £7 million. So we are reinvesting every single year, and we are working through the highest need areas. So Malvern is indeed on the Dental Services Equity Audit as an area of need. So we will be working our way through. So we've had to address the highest need areas first, but we will be working down it. And it's one of the wards that we're looking at.
Thank you very much indeed. Are there any further questions before I go to Simon Adams from Health Watch? Simon, please then.
I just wanted to ask one, and it stems from your question, Councillor Taylor, about the limitations. It's almost coming at it from the other perspective, about the limitations of the contract in terms of care that can be provided. Because I have had patients come to us and their dentist has said to them, well, you've got something like 5 or 6 functioning teeth, so I can't actually do anything for you because my only option is to take a tooth out rather than repair it. Is there any truth in that? Or
I think this comes down to the individual oral health needs of individual patients, Simon, I would say, and each case will be different. So depending on the clinical need of each individual patient will depend on the care plan that is then suggested. And I think, that comes back to code of conduct. So in that instance, I would say the dentist is acting in the interest of the patient rather than trying to fix teeth that actually would probably have a short-term life. I think he's been quite upfront with the patient to say, look, you've got limited options here. Of course, in that instance, you could opt for dentures to replace all of the teeth, but I think what he's saying is there's very limited work I can do to improve your oral health, given the needs of your current needs.
So we can tell people that there aren't any limitations in that the contract imposes to say, well, if you've got this many good teeth in your mouth, we can't actually do anything other than remove a tooth that is otherwise failing.
Well, it's about that oral health need of the individual, though, isn't it?
Well, no, I'm just asking you, does the contract actually say if you've got, for example, if you've got 5 upper teeth and 5 lower teeth, then you're good to go, sort of thing?
No, it wouldn't
doesn't
go into that detail. It would be about caring
Right.
for the oral health needs of the individual patient.
And the other question I'd like to ask that stems out of your question is, I mean, there was a time when, it's not all that long ago, when there was quite a lot of publicity given to dentists submitting fraudulent claims for work that they'd done. Does anything like that happen?
Yeah, so
now?
yes, indeed. So in terms of what we pay, so we look at the number of, they're called FP17s, which is the form that we all sign when we go to the dentist for the work that we have done. They are looked at by the BSA, it's a Business Services Authority, in terms of any areas of high need. So if you had a practitioner, as an example, that had very, very high needs for dentures, bridges, there would be an investigation to understand why, what is driving the population health need in this particular area that is driving continuous band 3 treatments, rather than a band 1 treatment where it is a checkup and on to the next treatment period. So there is a process in place.
Have you used that process? Because I think that goes to your point, Councillor.
We have historically. I haven't used it since we have been responsible as a commissioner in the last sort of 2 years, but certainly there were post-payment verification visits, they're called, in terms of assessing what has happened in an individual practice.
Thank you very much indeed. Councillor Turner's just indicated.
Yeah, just going on from what my colleague has said behind, I can't think of anything more abhorrent than having some work done to your teeth that it's totally irreversible. So I think that's a very important point that needs to be made, and make sure that any work is taken out is verified, and the patient feels totally confident that the work they're having done is necessary work.
I couldn't agree more, absolutely.
Thank you, Charmaine. Thank you, Councillor Turner. Councillor Kumar, please.
I think I'll go a bit further than that, what Councillor Turner and Simon have said. Like the hospitals do, audit every month. I think it's worthwhile because this is a new contract which is coming up. Rather than have a point of verification every 6 months or a year, it's too late, because every month things happen, and if they are picked up, things can be prevented from happening to some other patient. So I think it's worthwhile having a monthly audit of their activity and return to you. I know it's a bit more work for you, rather than point of verification every 6 months or a year, and everything detailed like they do in NHS hospitals about morbidity and mortality. So that is worthwhile looking into, rather than just how many teeth were pulled and how many were put in. Thank you.
I think in terms of courses of dental treatment, it's not as simple as just going through the door, having your treatment and out. These take months. They take absolutely months in many cases, particularly for people who are having a lot of work, just to actually phase that work into the schedule of the patient, actually, to manage the pain and the needs of the individual. So doing something on a monthly basis wouldn't be realistic, and actually it wouldn't give you the detail that you need. There is something here about looking at this on an annual basis, because you can then start to map trends and understand what is changing in the patient population that is driving that need of care. And that's the really important work around the population health management data that we do have access to.
Thank you very much. Are there any further questions on this, please? We're all very well versed now, aren't we? Extensive dental treatment. And if anybody's like me, I'm sucking on my teeth as I'm sat here thinking, hold on to them. Thank you very much. The actions we've got from this is that we've asked for a provision of a map of the training practices in Worcestershire and also request data from public health re fluoridisation versus non-fluoridisation. And I think we need to look at the business case around that going forward as well. Thank you very much, Mary Gay. Thank you so much, Charmaine Hawker, for your attendance this afternoon. Thank you, Councillor Bell. Thank you, Councillor Eacock. Thank you, Councillor Price too. Really appreciate your input, and thank you to Tom Grove at the back, who I know is going to surprise us with some more data. Really pertinent points we've been discussing here, and very much appreciate your attendance this afternoon. Thank you very much. Thank you. Members of the panel, we then move on to the work programme. Any items you'd like brought forward sooner than we have them on the list? We have for April, maternity and newborn services, the first 100 days, including maternity services, health visitors, screening, parental support and family hubs, and the update on the cancer pathway. And then we move to June, which is the urgent care patient flow and the work programme. We only have 2 items on that. Moving to July, we have end-of-life care. Is there anything anybody would like raised sooner or thinks we need to raise it as a new topic? I'd be very grateful for that. Any comments? No. Yes, Sam, do you want to?
Is the 27th of April the best day for councillors? Surely they will be busy.
I think we only have elections in Redditch.
Sorry, it's just Redditch now.
Yeah, okay. With the 3rds, I'm afraid. But so you might be very busy, but we'd appreciate your attendance if you can. I think health and well-being is really, really important to our residents, so I do think we should continue, Councillor Fry.
Indeed.
Just to say, members, we're looking at a refresh of the work programme, which will go to full council in May. So if there are any issues in the work programme that you think may not be suitable for scrutiny, please let us know, or indeed if you've got any additions. But it won't stop you adding to the work programme. It is flexible and it is a rolling programme, but it will be going to full council in May.
Thank you very much indeed, Sam. Thank you all for your attendance this afternoon, your participation, and which has been a very healthy discussion, and thank you so much. Goodbye.